microphones that can come around the room if somebody has a question.
Okay, you've discussed the very great time depth of religious origins of some of these concepts, forgiveness, reconciliation, that have come from, tens of thousands of years back probably as major social and cultural organizers. But religion also gives us another concept, a broad concept, a social concept of infallibility. Mm-hmm. So how do we address that, particularly as it applies to healing?
The concept of our own fallibility.
Well, of infallibility.
Oh, of infallibility. Oh, well, that's very interesting. But of humans as infallible? No.
But the thing that we emulate is being infallible, and therefore we influence the so many people say, well, you're playing God, and in many cases we are.
That's very interesting because, and I would imagine that's something, especially as medical educators, whether you're doing it formally or you're doing it as a mentor or role model, how do you build up the nerve, the hubris that people need to do certain kinds of medical procedures, like in surgery, for example? You have to imagine that you're not going to get it wrong, and yet at the same time say, oh, but you're fallible and fragile, and and things like that. Or there's in one of the books that I said in my book by Sandra Gilbert, who wrote about her husband's death in the aftermath of successful surgery for prostate cancer, but he died in post-op. She said before the surgery, this surgeon was literally holding out his hands and saying, these hands will save him. You can trust these hands. And she and her husband were like, wow, we're in good hands, And then afterwards, he was saying, well, he was like, I don't know what happened. I don't know what happened. But the surgery was a success. And and she writes about this book, he kept calling her up and saying, we got the pathology back, and it was a good thing you went with that surgery. And she said, but he's dead, And so it was deeply confusing to her and very, very distressing. So I don't know how you can deal with this except directly. I remember I used that some of the things that her surgeon had said. I was giving a talk in a narrative medicine program. So I was working with these first-person stories. And I remember this resident said to me, he put up his hand and he just said, well, you're not a surgeon. Things can go wrong. You don't know what happens. But then he said, oh, but I can't believe he said that to her. And so it was both. It was the idea of things just happen sometimes, but I certainly don't want to be a jerk when I talk about it. There was this human side of there's a right way and a wrong way to talk with someone. So I guess you have to acknowledge it directly. And so, if you're talking all the time about how you're fallible and make mistakes, it's hard to imagine that someone's going to place a lot of trust in you with a very delicate sort of a treatment. But on the other hand, if one starts to believe that one will never make a mistake, I don't know that many early career physicians. When I eavesdrop on medical students or early career doctors, they talk about you never forget your first one. They expect that this will happen to them. They do wonder how they're going to be prepared to deal with it.
So my question is about harm that isn't accidental, but neither desired, but rather instrumental. Everything we use is poisonous, unpleasant. Nobody likes to be in the hospital. Much of what we do is harmful by its nature. So there are new harms introduced with chemotherapy, dialysis, chest compressions. And yet, as clinicians, we're compelled to offer and deliver these things to people. So even when there's not an accidental outcome where a person might say, I'm sorry this happened, I didn't mean it. There are many cases where I did mean it, and I'm still sorry. So how might the ethics of forgiveness work when it's not an accident, but it's part and parcel of what you do as a provider?
Well, that's interesting because I think and this is something, it's interesting, this came up with respect to the guidelines. We talk a lot about, constantly we talk about benefits and burdens of treatment. And certainly chemotherapy is always burdensome. And the goal is to get the benefits ahead of the burdens, because no one would sign up for something that had more burdens than benefits, negligible benefits. Well, no, someone might actually sign up for that, but it's very important that be very, very clear what the benefit is. But I don't know that burdens and harms are the same thing, because harm suggests either an intent or some omission or commission that, I think if you do not alert a patient to the burdens of treatment and they're surprised by this, that can be experienced by the patient as a harm. I didn't know this was going to put me in the hospital. I didn't know it was going to trash my immune system. I didn't know I couldn't spend time, with my family because I'm so ill. Why didn't you tell me this? So there are ways beyond the physical, I think, that a patient can feel harmed by something. But the location of it may be in the communication. The doctor may feel like, but I told you, but there was some lag in the communication. But I don't know. I have difficulty calling a treatment burden a harm. I don't know if others have thoughts about this. I mean, it could be harmful to the person's body, definitely. The toxicity is harmful to the body, but I don't know if it feels, because that word is so associated with a mistake. I don't know, do others have thoughts about this? Oh, yes.
My problem is, forgive. Forgive something that somebody does with malice. Okay. I'll trade you. Forgive. There is a malice in that. There is an entitlement that I feel on the part of the forgiver. We are above, you did something bad. I have the right to forgive you or withhold it. It's a power. To me, it's an entitlement. We were God. And the problem here is that doctors are treated like gods. And sometimes they think they're gods. And that is a fallacy. And we need to put us in our place. And I did go to medical school. But it took a lot on my part to accept and reconcile that. Of course, I became a psychiatrist. I didn't become a neurosurgeon, which is a lot easier for me to handle it. But, this forgiveness, I think that we have two victims to our humanity. And it is hard to accept that we're human. We have the victim, the patient that dies or gets hurt, the family that loses the relative, and we have the doctor that made a mistake. Nobody does surgery planning to make a mistake and wanting to make a mistake. And by the sense of calling this a forgiveness, a need to forgiveness, I think I have a picture at home that says, to understand is to forgive even oneself. And that's very hard. It is very hard to hold us to such standards and to forgive us. That's hard enough. And anyway, I just wanted to share that.
Thank you. I think someone there? Yes, in the back. And also over there.
Okay, I'll go first. Okay, so I have two short questions. The first one is to like, so by practicing self-forgiveness, are you saying that like the clinicians are going to ignore asking for forgiveness from the other party?
Not ignore. I think I agree with my. Let me get this on. Maybe I can use this. It's just that the little light has, the green light has gone out, so I think it might be the battery. I think that what one just needs to make sure that you don't do is substitute forgiving yourself for the reciprocity with the patient. In other words, say, well, I've forgiven myself, so that sort of takes care of what the patient might be wanting to do in recognition of the things that I have done, which, disclose, apologize, help them to secure compensation, done right by them. They may be wanting someday to detach from what's happened here, but we can't rush them. That unfolds in its own time. And also, you also have to tend to yourself to say, in other words, what is the thing that I have to do so I don't hate myself, absolutely hate myself. And I remember talking with a friend who's a physician, and this is years ago, and I said to him, what does self-forgiveness mean to you? And he just said, freedom from guilt and self-hatred. And people just kept talking about their, feeling, just in despair about what had happened, just, not wanting to touch someone or thinking they had to leave the profession or something like that. That isn't the patient's problem. They have other problems. But I think as long as we don't conflate them, they may even happen on totally different trajectories. Okay. And you had another question?
Yes, that leads to my second question is like by practicing self-forgiveness for like repetitively, would that lead to self-pride?
Practicing it, what was the word after self-forgiveness?
Repetitively.
Repeatedly, oh.
Yeah, repeatedly.
Well, I would hope not. I don't know. I don't think if the stakes are as high as they would be having harmed a patient, the idea that would be easy to, like especially what Jeff Bluestein says is to he's really saying hold a mirror up to your past self and say, this is really what happened, and this really was my role in it. It's not an affirmative, I have to forgive myself, I have to give myself a hug or something. It's saying, I really have to know what happened there, and that's hard, really undertaking that self-examination. And sometimes doctors will say, I'm still thinking about something that happened, and they'll say, on October 23rd, 1985, when I was a resident. They really are still turning it over in their mind, and their willingness to talk about it is part of how they, perhaps part of their self-forgiveness process, but it's also how they keep it real with students to say, this really did happen to me, and I'm really going to talk with you about it, because I can't tell you that you have to face it if you never hear me talk about my own mistakes. Oh, there's someone over there. There's two people over there. The patient person in the back.
Yes, for physicians or surgeons who have asked for forgiveness to the relatives, who have died, and tried to compensate, as you have said, for the family, how often do they get sued? What is there? Do you have an idea, like the percentage of these physicians or surgeons who acknowledge that they have made a mistake, they have asked for forgiveness, they have tried to compensate the family of the dead person? How often do they still get sued? I'm just wondering.
I'm going to throw this question to my learned lawyer friend, but I think that the thing that we were talking about is disclosing and apologizing. I doubt there's data on asking for forgiveness right off the bat, but I think that could itself be perceived as rather oppressive, the idea of, well, and I hope you'll forgive me. A family could be saying, you want something from me? I remember that the forgiveness part may come on a very different trajectory, But I think perhaps what you're asking is, what is the relationship between disclosing and apologizing and whether or not litigation is pursued? And it's not a simple answer, but I think Lee would probably be the best to say a bit about that.
Thanks, Nancy. I think, there's a couple of ways to look at the question. One thing that I think is really interesting is the fact that you remember that Harvard did a study in the early 1990s. Most people who have sustained medical error don't, in fact, initiate a lawsuit. The data then said only about 8% of people who sustain harm as a result of medical error initiate litigation. So there's that piece. The data that has been emerging is fairly thin when we're looking at the conversation Nancy's now having with you in terms of the connection between authentic disclosure and then followed by litigation. There you can look, for instance, at the Lexington VA, which is the ground zero for the disclosure movement. And what the Lexington VA showed after a longitudinal study of being very proactive in their disclosure programs, that the number of claims increased, the aggregate cost of the claims dropped the Lexington VA into the lower quartile of what was being paid. The University of Michigan is another study. They have another longitudinal study. And what they show is that in the wake of full disclosure with a robust transparency and apology, that their claims have dropped in half. I helped Stanford design their system. After about 5 years, Stanford's claims are down by 36%, and they also have this very robust disclosure and when there is error coupled with an apology.
Oh, hello. I was given the microphone, so I don't want to take away from what we were just discussing with actual lawsuits coming about in harm cases and that kind of. I actually wanted to go back to Dr. Morrow's point that he brought up with harm that we perceive as physicians. I'm Lena Ghosh, I'm an internist, and I also do palliative care in the community. And that I do feel that there are differences between physicians of different disciplines as to if we are actually causing harm to a patient by our interventions. And that I actually thought of a particular case in that I was a part of as a palliative care doctor. And this was a patient who had I'll discuss it just very briefly. It's a patient who had a very advanced myeloma and was also an elderly gentleman, like 83. And he was in the hospital and pretty much near active death while he was in the hospital when I saw him. And I had had a discussion with the family about him not being resuscitated in the event of an arrest. And this discussion had not been completely resolved, and the gentleman did undergo a respiratory arrest and then was intubated and put into the intensive care unit. And I actually felt internally very conflicted because I felt that this was a harm that was done to this particular patient in a way that the events in the ICU were not going to change his ultimate demise due to his advanced disease. And that this gentleman was taken off the ventilator after 2 or 3 days and did die within a day. And so I felt that despair that we actually talked about a little bit in terms of how could I have prevented this from happening to this patient, and that the family would have never considered this a harm done to their loved one because this is what they were told would be the step if your loved one can't breathe, we put this tube in, he goes to the ICU. But I think that our perception of harm as physicians can also be a powerful part of if we can ask ourselves for forgiveness. It may not be actual harm that the patient sees and the family agrees, like this, the medical establishment has done harm to us. But that perception of harm from our own internal viewpoint can be just as powerful in that we have conflicts with internally.
I'm very glad you brought this up because there is a phenomenon that's sometimes called moral distress, the idea that you know what the right thing to do is and you're being forced to do the wrong thing or you're not allowed to do the right thing. And it's often been studied among nurses and residents as a hierarchy problem. Somebody else is telling me I must do X. But I've been struck by some examples that I've heard from very senior physicians ICU chiefs who'll say, I feel like I'm torturing this patient, and yet here's the advance directive that says he wants this, or the patient is competent and he's telling me he wants this. And just there's something about these interventions, or I wouldn't choose this for me. I don't think he should choose it, but it doesn't. Just knowing that this is someone's choice or a surrogate's decision is not assuaging these feelings. And being in touch with this is hugely important. It's really hard, but what you do is hard. So I think that is, and it might even, your brain might say, what I'm doing is wrong, a mistake, or this shouldn't be happening. So I think having a way of talking about this is part of what an academic medical center can do for the people it's training and the people who work in it. And also because some of these, a person can, I remember learning this from a hospice doctor, a person can be very near death and still be the victim of an error. Something can still go wrong in that person's care, and so one always has to be attentive to this. Yeah, that's another piece of the picture, and yet it's hard because it might, you might have there's no disclosure really. There's no one to talk, as far as everyone else is concerned, you're doing the right thing. I'm glad you brought that up because these things can, I remember a neonatologist who said it can happen, that perception can happen very quickly. It's going along and then something has changed in the patient's condition and all of a sudden you feel like you're torturing them. But how do you even talk about that, So, thank you for bringing that up.
Yeah, I had a question about the transparency in our society. I mean, we advocate that as a good thing, yet at the same time, being so transparent, especially if things get into the social media, it seems like the piranhas come out. If someone makes a medical mistake, and even if they try to repent or whatever as it were, they can be torn apart. I mean, there was a Seattle nurse that committed suicide after making an error in the NICU, and even that case in England a couple of months ago was horrible. And, certainly there must have been other problems, but I'd like you to address the social media issue, transparency, and all the complications that keep this from being a, quote, pure process. Oh,
that's a very good point. When To Err Is Human came out, I don't think anyone except maybe the person who was coming up with Twitter had ever heard of it, or Facebook wasn't nearly as prominent. And so we're in a different and ever-changing world on that front. And yes, if a nurse who was caring for the wife of the heir to the British throne, or the grandson, can kill herself because there was a practical joke, and somebody called and she answered it, and this poor woman. So this is something again that is discussed frequently. In other words, should you friend your patients? What do you do if your patients friend you? Should you blog about your patients? What if they blog about you? And so on and on. I don't know that there's going to be a simple answer. I think maybe risk management will tell you, never talk to anybody about anything, but, well, I don't want to be a caricature, but, and someone else may tell you something else, So I think, making sure that's why ethics works well when it's interdisciplinary, to say, what are all of these things that are going on? We want to make it easy as possible for patients to have advocates with them, and there's somebody watching us all the time. And we want patients to be able to establish websites to keep in touch with their loved ones. And, does that mean someone else is watching us all the time? And so on and on. The diversity that we have, or the idea that our hospitals are open, and it's not two people who get visitors passes to come in, for 2 hours or something, but you have people sleeping there and bringing food and such, also can add to the sense of tension sometimes. You have a lot of people around, and is somebody going to question when something that is right looks wrong or looks questionable? I don't the sharpest ethics committees that I've observed or been part of bring this up regularly. They don't wait for a crisis to happen. They don't do it as a root cause analysis. They say, so what about the fact that our organizations are more porous now? You know, what about the tension between transparency and privacy? And so, you know, but I think that is hugely important, the idea that more people are watching what you're doing. Absolutely. I mean, I was on a task force recently about a policy that whether healthcare workers should have mandatory seasonal flu vaccinations, and I was part of the task force. And I got a call from somebody in a state very far from where I live saying, "Can you tell me how I can do X in my hospital?" And I'm like, "How did you find me?" Well, she had looked up the proceedings that were part of the full disclosure law and had gotten me, and I'm thinking, oh my gosh, wow. so you know, there's a lot of things that are on the public record now, but that's just part of the environment we're in now. I don't think there's an easy answer, but I'm glad you brought it up. Yes.
As a chaplain, I can say the Bible says, guard your heart. And whether they forgive you or not, sometimes it's very hard to forgive ourselves. And sometimes we don't have the power to forgive ourselves. That's when we go to the higher power to say, Lord, forgive me. And help me to forgive myself because I can't. And then peace comes over your heart. But we need the Lord when we cannot do it on our own.
And thank you. And I'm sure as a chaplain, you've also had situations where it would be, without knowing the full dynamics in a family, it would be inappropriate to pressure people to reconcile. You know, one person may have harmed one another grievously, and someone else may be saying, but shouldn't you try to bring them together near death? And you might have to say, that's not something I can do. No. Oh, there's someone here. I think that's probably got to be, no, we're going until 7:30? Okay, good.
It seems like in this country, especially, and when you talk about studies, the context is really important, that when there's harm done to a patient, that might result in need of medical expenses far into the future. Mm-hmm. And so to try to get compensated or to have that expense paid for, it's almost like an adversarial situation has to be set up the mm-hmm. way our legal system, our healthcare mm-hmm. system is in this country. We have to sue to get compensated for that future care, since we do not have a national or a single payer healthcare system. It's easier for the VA, for example, to do, you know, to admit to injury because they're going to provide that care into the future forever. So that takes away that incentive to sue to get that care into the future. So I was wondering if you, I believe I've heard about how Sweden, the situation there, they have a national system, but they've set up a national compensation mm-hmm. fund, right, so that whenever a harm or an injury occurs, immediately the physician who's been involved in that starts helping the patient to mm-hmm. access that mm-hmm. fund. We don't have anything like that in this country as well.
We do in a bit. In Sweden, Denmark, New Zealand, and one other Scandinavian country, I think Finland, have no-fault systems. They also have universal healthcare systems, so it's a feature of the system. And in Denmark, I mean, you can go online and fill out your form, and it's all pretty. The idea is we've all paid in, and we all, sort of get it out. In the United States, as you rightly point out, because we don't have a single-payer healthcare system, we've got a fragmented system. You still do see approaches to this, as Lee mentioned. The University of Michigan system is a very large system that includes the hospitals and also includes a lot of the doctors. So in their approach to risk management, focuses on settling claims and trying to avoid litigation. And so they have something like that approach, and they've actually polled the doctors in the system too, and have gotten very high satisfaction. You're saying, it feels like the right thing to do, my premium stayed under control, so they poll patients and they also poll the doctors. But probably the example that gets written up the most is the 3 Rs program in Colorado, which is run by an insurer called COPEC. So they insure both the hospitals, but they also are a med-mal, they insure the doctors. So they have a no-fault program that goes, it's got a cap of like around $30,000. So it's not for very, very large expenses, but it's very, very well thought through. So what doctors have to, they receive a lot of communication training, they're partnered with a risk manager. After it's all over, the doctor's the head of the program, calls up the doctor and says, okay, so how are you now, kind of a thing. So that's just, but my understanding is that hasn't been replicated very much in the insurance industry. But then I always remember, in my book I talk about Catholic Healthcare West, which is now called Dignity Health, a very large system on the West Coast. And they realized that all of their hospitals were never all going to do exactly the same thing. There were just too many of them. But they they came up with what they called the philosophy of mistake management. And their idea was they took the words that are on the wall in the hospital or on the website, our excellence and stewardship, and they said, what do these things mean when we hurt someone that we were trying to help? So to say, what are our first principles? And one of the things they said was, part of our stewardship is using our insurance money responsibly, which means sometimes we use it to compensate people, or sometimes being responsive to patients. Justice means that we will tell them, you should have a lawyer because we have legal counsel. If there was a very big power imbalance in the room. So there are ways that sometimes a system has thought it through. I think one thing that's always problematic is if there's no way for someone to get compensation without filing a lawsuit, it puts one in the category of being a litigant right away. So that's always interesting, is can you actually secure some form of compensation without taking the first step of having to hire a lawyer? Very good question.
I have one question. Well, thank you for a marvelous talk. I have a little question, a statement, and then maybe a little joke. What I struggle with most is the word forgiveness, and it's kind of difficult to sort of walk around that. And I definitely don't see myself asking a patient for forgiveness. I will disclose, and this was my role in this, and all that. But to ask forgiveness really dumps it in his lap or her lap, and I don't think that the patient deserves that. They forgive on their own time if they want to. I saw a patient today who's 33 years old, real tough guy, was involved in a gang, and he ended up in the hospital with a bad encephalitis and meningitis. And the doctors knew he was going to die. They just knew it. They told his family. They prepared his family. And is he Catholic? Well, let's call a priest. And so this young priest comes to the bedside. This guy can't talk. He can sort of see. He remembers a few things about what was going on, but he can't talk at all. He's just sort of blah, 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 blah. And trying to talk to this guy. And the priest sees how agitated he is. And he says, don't worry. Everything's going to be fine. It's like being born again. And he just wanted to strangle the guy, Things just get all confused at that point. And so it's more a point about communication at end of life and what really needs to be said, and harm can be done by any member of the medical team.
Right. Well, exactly. It reminds me, there's this, I've done some research projects on chaplains, and they have these funny sayings. They'll say that your job is to get yourself out of the way, like yourself, like not going in there with your script or your agenda. But they'll also say that their job is to sit down and shut up because they're listening. They're meant to be listening. And sometimes people come and they're trying to fill a silence, or they're not quite sure, they don't know what the diagnosis is exactly, and so they extrapolate from something else.
That's true. I think they are at a disadvantage. They're just told to come to the bedside,
right? And
they know nothing about the case, and nobody wants to violate the patient's confidentiality.
Right.
So they are at a big disadvantage.
Yeah. So that's something some hospitals do try to involve local clergy in, sorts of basic training, if you're going to be at the bedside. But it's hard because their world is very different from a chaplain's world. They're very different from a doctor's world. But I remember giving a talk in Cheyenne, Wyoming, where everyone knows everyone, and there's like one rabbi there's one moil for the whole state. One person does all the brisses for the entire state. So, and people were just talking about these very complicated scenarios that they had to get good at because, they would be called in, here's the person who's the member of this particular denomination and you're the guy, and they were talking about things in a very sophisticated way. And so, that's just probably because you have this community presence here and such an amazing community, might be something to just try out every so often, being prepared to come to the bedside. I have a friend who wrote a book on a clergy guide to end-of-life care, and she said clergy are no different from anyone else in terms of their fear of death, their concerns about mortality. They're not necessarily, they might know about funerals, but they might not know really how to approach a sick person.
We have time for our last question right here, and then after that, we'll thank our speaker, who will then be outside signing books, and if you have any questions that you want to talk to her about, that would be great.
I must identify I'm a layperson, not a physician or a caregiver.
Oh, so am I.
I would say it was very important for me to come to this presentation because it surprised me that in a medical school, the doctors and to-be doctors and caregivers would be talking about forgiveness. It is also my belief that it's very important what you guys are talking about. I also believe that the great unwashed masses of us patients would be amazed that you are. Because there are many, many of us who believe that physicians generally believe they are infallible, and no one really is. But it is a delight to see this type of education going on. It's a delight to see students and physicians also, and caregivers, nurses, attending and discussing forgiveness. It's great for a patient or for a layperson to see that. Thank you.
Well, that's great. That's a wonderful last note. That's terrific. Thank you.
Thank you.
Great.
That was fantastic.
That was fun. Good. Great job. It's much easier to talk about this topic in Texas than New York. Well,
We're less too happy.
well, yes, exactly. New York's like